Thank you. Thank you. My name is Pradeep Deshpande. I'm a rehabilitation medicine consultant in the UK. I work in Hull, and I'm presenting some of my experience about setting up a mild injury clinic with my psychology colleague. So after a lot of operative interventional world, we're gonna slightly move to the rarefied psychology and head stuff and what it can do in rehabilitation, and share your case. I'm sure the time will come. So just use this for.
Yeah, you can use that. Just
So before I dive into the actual presentation of what is mild head injury, everybody knows that the classical coma scale is used to divide the head injuries. So when we set up this clinic and when this service was set up, it was in a major trauma center where you deal with all kinds of trauma, right from the emergency medicine, which is ED or A&E as we call it in the UK, to the orthopedic ward, to the major trauma ward with the neurosurgery ward, where moderate and severe head injuries are treated. But we were looking at what happens to the mild head injuries who go home within a week. And this is, even though it's a model in the UK, it's very much favored in the US, where people are kept in the hospital longer if they recover physically from head injury. And physical recovery, as we all know, happens quicker when there is a trauma. And this now is being recognized more and more, that not only in the frail elderly, where there is a trivial trauma causing more problems, cognitive and long-standing, we are also finding out that even in younger people, if you are having mild head injuries and they are undetected and untreated, and they have a long-term sequelae which are quite devastating. There were recently examples, one from a Scottish rugby and one from the UK, in which the repeated head injuries have not only caused the person to become suicidal, but actually two people, the ones they are in the domain, in the public domain, have actually committed suicide. So mild head injury is not something to be taken very lightly. Most of them recover, and what we use is a term called post-traumatic amnesia, which again is well known, where you look at the immediate memory after the occurrence of the concussion. Now, many sports have concussion, whether it's rugby, whether it's football, even cricket, American. And what the protocol is, if concussion happens, the physiotherapist or the doctor or both will come and administer some tests of orientation and make sure that the person is ready to go back. And there are lots of other protocols. If the person is not able to make immediate recall, then they are taken off. So post-traumatic amnesia is a very important thing, and I'll come a little bit how we measure that. So what we decided was a service which was designed mainly to pick up these people who go home. We are not so much focusing on concussion, because concussion in the UK is mainly treated in A&E. They don't reach hospitals. They go home from A&E. Whereas I'm only talking about the people who end up in a hospital, stay for less than a week. So how do we triage them? And me and my psychologist colleague have taken some information from one of the American guidelines, which has come recently, and the NICE guidelines, which is the UK's Bible, the National Insurance, the National Institute of Clinical Accident. So what they are suggesting is you should have a protocol for positive CT, where the positive means it could be a small contusion, it could be a small hemorrhage, it could be a small fracture, or some evidence in the brain that there is a injury which has occurred. Now, there will be another similar slide for CT negative, where actually when there is nothing on the CT, and we know that symptoms of mild head injury, symptoms of concussion and post-traumatic amnesia can happen even if there is no evidence on the CT. So what we decided that we would take the ones who have a mild CT findings and take, say, for example, Glasgow score scale between 13 to 15. They are monitored on the ward. They could be admitted for, say, less than a week, maybe 2-3 days, maybe 5 days. Somebody would have a comorbidity, maybe a fracture, may not be any limb injury, and they would do a test called as a Westmead PTA assessment. So Westmead PTA assessment, all tests for head injury are basically in 3 or 4 main domains. The first domain is orientation. The second domain is about executive function. Third is about recall, which is short-term recall. And there are various ways of measuring it. The good thing about the Westmead is it has got a 12 items in its scale, and it measures, along with everything else, the ability to retain the information. So a person who has a post-traumatic amnesia will be in the hospital at least 3 days, where the PTA scale will be measured and the new information that the person is being taught is tested, whether he or she remembers that. Now, the importance of the Westmead is if somebody has a 12 out of 12 for 3 days, then they are deemed out of PTA. And then they are discharged home safely from the psychological point. If they have other things, for example, they have to fix a fracture or if they have cervical spine injury, that's a different thing. But this is what we use for purely mild head injury. Okay, so as we go down the slide, we say that suppose somebody does have a good score and they still have problems which are deemed to be not resolvable with the PTA information, then we administer a test called MOCA, which is a Montreal test for cognitive assessment. So this is a 30-point scale test where they would look at these domains in more detail. So orientation, short-term memory, executive functions will be looked into more detail. And if they are deemed to be making 23 plus or 24 plus score on MOCA, they are discharged home, and not if they are less, then we administer them some kitchen assessment and personal assessment to see if they are showing the sequelae of the mild injury. If they are safe for discharge, they are seen in the community by the occupational therapist, and they are also seen by me or my colleague in our head injury clinic. So what is the importance of doing this PT assessment and why should it be done in a particular way? PT assessment is like any other assessment where the person is first made, it's made clear that the person understands what's been asked. It is a different assessment than what you see on the field where they will just ask the person to follow the finger and this and that. This is more about the patient's understanding and recall. And that is why it is measured in such a way that language barriers are to be taken out. The patient is kept in a very quiet environment. The patient has full concentration. He understands what is being asked. And there are sometimes speech and language therapists who help when there is a aphasia. Because all this can affect the PTA scale. The pathway for CT negative is much simpler but similar, that we would still observe the GCS, they still observe their Westmead scale if they have a short-term memory problem, and administer the MOCA if it is persistent for more than 3 days. Now you have to remember that with any head injury, but particularly mild variety, you get good recovery in majority. That's what the studies have shown. But if the PTA or if the cognitive problem persists beyond 3 days of short period, then there is a danger that this is not just a PTA, which is a post-traumatic amnesia. It probably either a severe, which is moderately severe head injury, or if there are no other signs of moderately severe head injury, this is a cognitive impairment. And this is particularly important when there is an elderly person who has some background of forgetfulness. I hate to call dementia because it's not a good word to use, but it does convey a meaning. So if there is early dementia, then you need to know whether this is a new forgetfulness or this is after the head injury. So there is a difference between a short-term memory loss due to a mild head injury and a persistent memory problem, which could be either result of the head injury or because of the pre-existing condition exacerbated by. And you have to remember that CT can be negative. That doesn't mean the MRI is always helpful. It doesn't. These are some of the things which the imaging does not pick up. Again, the protocol is not very different, so I don't want to repeat that. So what does the clinician, the physical rehab medicine consultant do, and why? Why do we need to actually involve that person? I've got a case study to illustrate the importance of why a medical person of physical and medical PMR background, I know it's called as physiatry in the US, we call it as a PMR now in the UK and Europe. So what we do is me and my colleague, we do a series of questions on the telephone, which could be anything between 2 to 4 weeks after the discharge from the hospital. And they include symptoms like, do you have headache, dizziness, loss of smell, hearing loss? These are quite obvious why we ask these questions. Sometimes nasal dripping of clear fluids, which shows CSF leak. Mood, anxiety, depression, confusion. And the earlier cases which I had said had a repeated contusions, repeated mild head injuries, playing either rugby, even football nowadays. They are saying that people who head more are likely on in their 50s to develop dementia. Boxing, we already know, but boxing is in my opinion, a brutal sport, because the whole aim of the sport is to make the other person dizzy. Whereas I'm in the business of treating head injuries, so that's my personal view anyway. But mild head injuries where people recover, in sports where there is a pressure to go back, you've got a game of 90 minutes, you're playing a World Cup final, you have a bit of dizziness, the person wants to go back. Whether it's rugby, whether it's football. Nowadays, cricket has become more savvy and they get the person out and get somebody else in. But in olden days, if you look at some of the videos, people are falling down after getting hit, taken away, and then again coming to play the next day, which I think is absolutely inhuman thing to do. So memory loss is a huge thing. And this memory loss, if repeated mild head injury happens, can become permanent. Anxiety. This anxiety and depression is the one which eventually then kills the person. And what the anxiety does in mild head injury patients over a long term is they are afraid to go out. They are afraid to face anyone. This is a very significant change in a fit athlete, skilled person. And obviously we know about fatigue. So what we do is we do this kind of symptom assessment on the clinic. Most of the clinic would be saying the patient is fine and then they get home. It would very, very rarely that something of this would flag up, and then we have a system of calling them back to re-scan them. Insomnia is another common one. Most of the clinic would include referring to physiotherapy, to exercises, use of antidepressants, use of our ophthalmology colleagues to do optometry. and my psychologist colleague to do a psychology assessment where he does a mood and cognitive assessment in his own screening method. The idea of the screening method is if the person screens for a higher cognitive problem, then the person is called back for one face-to-face cognitive assessments and further strategies, which we call as cognitive rehabilitation. So the main outcome that we look at is obviously return to full independent living, if it's an elderly person, for ongoing support in the community, or things like return to work and return to driving. Return to sports should be an important one with the sportsman. These are the common causes, depending on the socioeconomic status. Most of the men will have road traffic accident. Again, common is fall from the ladder. Assault is more common in men. Road traffic accident, I take it, can be for ladies and men together equally. So we looked at a 6 months clinic audit of what the experience showed, because the clinic was started mainly at the behest of the psychologist, and we worked together. So we, in the 6 months, had about 26 patients, so one every week, predominantly male. So we expected that. It was quite interesting to see half of them showed some kind of CT finding, either contusion or. We have to also realize that if it is just a contusion, the neurosurgeons are not interested, and there's nothing anybody else can do, and they just discharge the patient home. But we managed to get 12 people back to work. We managed to get almost half of them back to driving, and most importantly, all were discharged home. Now, I did say in the beginning that they were discharged home, so it's a bit of a confusing statement that all discharged. They stayed home, is the point I'm making, and they did not need to come back to hospital. So this is a case of a 56-year-old man who came in the hospital after he was driving in a car, and the car rolled into a ditch. He was diagnosed by the scan as a small traumatic subdural subarachnoid. The surgeons looked at the scan, they were not very impressed in terms of, they were impressed, but they were not impressed doing anything about it. He had some fractures. He had a fracture of his parietal frontal bones, orbital fracture, but no diplopia. He had a bit of a, what we call commonly as a black eye. So we got him to see our maxillofacial colleagues, and they said, oh, this is just needs to be managed conservatively. So the Ghoul is a place in the east of England, and it's a rehab unit, so that's why it's called Ghoul Rehab Unit. So he was sent there. This was his scan. Just concentrate on the frontal side. There's a bit of a bleed. Apart from that, pretty much okay. Mid-50s, a man who works as executive level of work, sort of responsibility. Did not report any significant memory problems, did not report any significant problems with his executive functions. So when his eye swelling was subsiding, he was called back by ophthalmologist to look at the vision, and he said there was no diplopia, range of movement of his eyes was okay. Did a full optic assessment, but it was normal, and then he was again discharged, saying by the oral maxillofacial surgeon that there's nothing need to be done because the zygomatic fracture usually, and the facial fracture usually is conservative. So now what happens is he's gone home, he feels better. He was given some prophylactic anti-epileptics, and now everything is fine. The only thing he says, my taste is a bit affected, and I want to go back to driving. So smell is okay, and that is a bit of a worry. Normally, you do get in a frontal injury smell and taste affected, which we do manage in a different way. But he also had no clear history of nasal drip. But because he was going back to driving and he wasn't sure, I called him back in a face-to-face clinic. This is his repeat scan. No symptoms pertaining to headache, no symptoms pertaining to nasal drip, no symptoms pertaining to any other like dizziness, just different in taste. And he attributed it because he thought he was a bit of a runny nose. He was going through a bit of a cold, and that's why his taste was affected. But it was his wife who pointed out that this is going on for too long. So we called the maxillofacial team and we looked at what was going on. I don't have a pointer, but if you look at the top, he was developing a fistula where his brain and his CSF space was slowly leaking. And because it was situated in such a place that when he would look down, his drip stopped. And I think my guess is his brain was blocking the drip. And when he looked up and the brain moved back, the drip started. This is a very dangerous situation to be in, particularly if you're living in a community, because he could develop severe meningitis, severe brain infection. It was very lucky we caught him up, got him operated, and the intermittent clear dripping stopped. He was diagnosed stable during tear. So the early point I was saying about why you need to see a doctor is there are certain complications of head injury which are delayed. And there are certain complications of head injury which are very, very serious, apart from the one I said. So this is not a very common occurrence, but it shows why it's important to work with a psychologist and a nurse and a doctor, even if they are not in the same office, but to be interconnected so that you refer the patients to each other. These are some of my references. There's a huge amount of work on mild head injury, and the model is pretty much similar that you follow them and do a symptom inventory and make sure that you don't miss the obvious ones. Thank you for listening.